Good morning, Steve Steins, Chief Medical Officer here at the University of Kansas Health System. We're back with you. Today is an incredibly special day. It is our 100th episode of our morning media program, talking to you about all things true and honest about coronavirus and speculating about those things or not, but always with good intentions.
Yeah.
I'm here with Dana Hawkinson, Doc Hawk, our Medical Director of Infection Prevention and Control. We're inside the Dolph Simons Family Studio, and we're delighted to be with you on this, our 100th episode. Joining us today are two very special guests. One is Tom Bell, the president of the Kansas Hospital Association, president and CEO, and Herb Kuhn, who is the president and CEO of the Missouri Hospital Association. Gentlemen, welcome. We're delighted to have you with us today. I'm going to ask Doc Hawk a question, but first I'm going to reminisce, and then we're going to go through kind of an opening for each person. You know, we started these regular updates about 21 weeks ago. I remember Jill was telling us about how we structured it, and I kind of forgot about it. And actually, I look back at it, I'm like, oh my God, what were we doing? But we had a phone right here in the center, and we were all huddled around the phone, and there was a row of reporters right here in the very front of us, and nobody was socially distanced from anything. And we were all kind of talking back and forth, and we try and give answers to questions. We didn't wear masks. I think the distance between us was 6 inches and not 6 feet. It was a little tricky, perhaps. We tried to carve out time every day to answer media questions. It jumped around a lot about SARS-CoV-2 and COVID-19, and we were trying to figure out how we were going to deal with this pandemic. The media asked great questions. We would bring in experts to help us with those answers, like experts like Lee Norman. And then as it progressed, we also found experts to help us answer questions from our health system, about cancer, about the School of Medicine, our community, all sorts of folks. And then we started having questions from our community itself. And I think that's been perhaps one of the best things we've done, is to be able to get questions from all of you, our listening audience, to try and answer your questions and concerns as best we could. We started that day with our numbers, and we've been giving our numbers every day because we try to be transparent and honest about where things were. And here in our 100th episode, Dana, I see no reason to not do the same. And I think Dr. Fauci is agreeing with that. Transparency and honesty. How are we doing today?
That's right. You know, I had to work yesterday, so when I came in, I did check the numbers, and they were really good. I was pretty happy. 23 patients yesterday.
That's good. That's good.
But I came in today, and we have 31 in the hospital right now.
Ouch. Why? Did nobody go home yesterday?
That's unfortunate. We just had a lot of admissions.
We did.
We had a lot of admissions. And I don't know, you know, certainly we have seen in COVID that nothing is predictable. So there are going to be highs and lows of the amount of people. We know that as you get new cases, hospitalizations follow those by 1 to 2 weeks. I don't know if this is part of that, but again, we did jump from 23 in the hospital yesterday to 31 today. So over the last 24 hours, we've had certainly many more admissions.
Yeah. Then we had discharges. And how are the ICUs?
Yeah, 10 in the ICU, but unfortunately, 8 of those, 80% of those in the ICU are on the ventilator right now.
Yeah, that's tough.
So this is a bad trend. Again, we will wait to see what happens over the next few days, but certainly
and
23
things bump
to 31.
up and down and up and down and up and down. But we were in the 20s all last week, so to be up to 31 is a change. So well, let's turn to the folks who are here from the respective hospital associations from Missouri and Kansas. First, Tom Bell. Tom, how are things in Kansas? How are things with you?
Dr. Steins, thank you very much for having me. I appreciate you allowing me to Skype in because I was a little worried that you might make me go to the freezer with you guys after watching you last week. Let me just maybe make a couple of quick comments. First of all, I want to thank you both for what you're doing and your entire team for providing a fact-based, knowledgeable, responsible discussion every single day about what's happening. It really is a public service, and I hope you all realize that. And more importantly, thanks to the people in your facility and in Kansas City and all across the state and country for what they're doing. You know, we talked a lot about healthcare providers in the beginning of this, but they've continued to provide care every hour of every day, and I don't think we can thank those folks enough. Just a couple of quick things about what's happening in our state, and because I know Herb's got lots of information as well. If you talk about hospitals specifically, it's always important to remember that, we're really talking about people at the end of the day, and the people that we're taking care of. But with regard to hospitals, they kind of received a sort of a triple whammy here. Number one, they've prepared for and taken care of COVID patients, and that in and of itself has been a very difficult challenge. But in addition to that, they saw the shutdown, which affected healthcare just as much as it affected any place else. And you had a gentleman on from Vibrant last week talking about the fact that people were reluctant to go into the healthcare system, and that happened with hospitals across the state. Probably a 40 to 50% hit in terms of volumes and revenue as we went through this, and that's gotten better, but it has not abated for sure. As a matter of fact, I think the figures are that we're expecting that 50% of hospitals are going to have negative margins in the third quarter, and those negative margins are going to be anywhere from -1 to -11%. The third part of this triple whammy is what we're in now and what we're going to be in for a while, and that is the aftermath, the toll on physical and mental health that we have seen and that we're going to continue to see. People putting things off, the behavioral health issues that we see as a result of this. So hospitals have experienced all that. I want to make a quick point, though. The CARES Act funding that the federal government came through with was extremely important, and it really helped hospitals to move along, especially through the second quarter. You all know, you probably have heard, we've had a couple of hospital closures in our state during this time period, the hospital in Wellington and then the hospital in Leavenworth. Both had at least some relationship to the COVID situation. So I think this is a trend that unfortunately we may see more of as we move on. In terms of the data in our state, you guys talk about this a lot, and your explanations are as good or better than anyone's. But we have seen in our state a bit of a leveling off. We've seen certainly a reduction in the number of hospitalizations per infection. That has gone down over time, and the fact that you all have done a better job of learning how to take care of folks probably represents a big part of that. And certainly, we've also seen a reduction in the deaths per infection over time as we've gone through. And I think that's a testament to the healthcare providers that are involved in treating patients. So it's a bit of a mixed bag in our state. Hospitals certainly have suffered, just along with other businesses and others. But I think we're learning better how to deal with this situation.
Yeah, and I think that's right. There is a lot of truth in that. We've gotten a little better at it. Unfortunately, it is an evasive foe. So, Herb Kuhn, how are things with Missouri hospitals? And welcome to our program.
Thank you. It's a pleasure to be with you. And I would echo what Tom said in terms of we're seeing some amazing acts of heroism as frontline healthcare workers really lean in and work to take care of everybody across this bi-state region, but all across the country and across the world. It's just been amazing to see what's going on out there. For us, a couple things here. One, obviously, we had a very important election last Tuesday. On the ballot here in Missouri was the effort to expand Medicaid. And we now will be the 38th state to move forward to expand Medicaid under what a lot of people call Obamacare. But we're thrilled and we're grateful for the people of the state of Missouri for that very strong affirmative vote. We think that'll make a lot of difference in a lot of people's lives. At least 230,000 people will get coverage in the state of Missouri. And importantly, I think it has a lot of relationship to what's going on in terms of this pandemic, because when you have 230,000 people outside of the healthcare system, their ability to come in to seek care is limited because a lot of these folks are quote unquote essential workers. There are a lot of frontline workers that can't stand down during these kind of times. And so to have them part of the coverage, I think it's just going to help us dramatically as we move forward. Now, we've got a lot of work to implement that, but that's an important issue. Other things going on in the state, I won't echo what Tom said. He covered many of the things, and you're seeing parallel things here in Missouri. But we're also seeing a massive age drift in terms of our population that are becoming testing positive for COVID-19. Our average age dropped from about 56 in March and April, and we're now in the low 40s. And I think we're seeing that nationwide that's going out there. So it tells you that we're seeing a big movement that has a lot to do with, in terms of hospitalizations, because this population is a little bit healthier. But as we get ready for back to school, what does that mean for us as we see this age drift and what's going to happen? So a lot of conversations in the state of Missouri going on back to school. And one final additional thing that we're talking about a lot in Missouri, and I suspect in Kansas as well, is what are we going to do about the flu vaccines coming up? A lot of folks are saying, get in line early. Let's get as many of these people vaccinated with the influenza and other, whether it's other vaccines that are available. Is this an opportunity for us to really work to try to improve vaccine coverage for the country as we move forward, but also the importance of getting all these people vaccinated as early as possible before we have maybe the COVID-19 vaccine coming forward? So those are some of the issues we're talking about here in Missouri as well.
Yeah, and congratulations on that Missouri Medicaid vote. As a Missouri resident, I was out of town during that election, but I voted absentee so I can make sure my vote counted, and I was delighted to see that.
That's
So,
right.
that's a good thing, and so congratulations with that. And yes, we have seen a younger population here,
Yeah.
Dana. We have definitely seen the same thing. You know, when we first started this, a lot of older folks that's kind of moved out of the nursing homes into the general community. I think it's still in nursing homes, but really the thing we're seeing is that there's been a lot bigger spread within the community as a whole and within young people. And we know that our mortality rate here runs about 8 to 9%, which is still really high. If you think about that, the influenza, the folks, we don't have anywhere near that high of a mortality rate. So 8 to 9% is a really high number for any single disease upon admission, and that's where we are. And it's across a lot. I mean, clearly as you get older, there's more at risk. That would be me. But as you're younger, there is still risk, and we've had 20 and 30 and even people in their teenage years pass away here from COVID-19. So it's difficult.
Yeah, and that, that 8 to 9%, again, we have to make clear that it's not all infections, number one, because we don't know all the infections. We know that it is spread out there, and some people will not get diagnosed because maybe
8 to 9% of people who got admitted.
Correct.
We had that's the number who passed away. So. All right, so let's see what questions may be out there this morning from media, and then we'll turn after that to our listening audience. All right, so Jill, I bet there's already questions mounting from our listening audience today.
There are. A lot of congratulations on our 100th episode, too, and a lot of compliments as well.
Just to say, the remarkable story is, Dana, that Jill and Anthony and Logan and Cliff and the people who are really responsible for this, Michelle, all these people have been putting up with you and I.
I know.
That's impressive, 100 episodes
time.
of that. That's a long time.
And all the wrong things we do. We try to learn quick, but
we're not educable.
They can only do so much with the camera and the microphone.
Okay.
You guys are great. We'll do another 100 more. Angela.
No, COVID has to go away. That's what we're all hoping for.
That's for sure. That's sure. We'll
That's
switch
the
topics.
sad part about 100 episodes.
Okay, Angela wants to know, over the weekend, Kansas City's mayor was on national television, and Dr. Birx was stating that Kansas City is among cities with the potential for a major surge in COVID-19. Why? Why are we being singled out?
Well, we're going to try and take this, and I'm going to pitch it over to Herb and to Tom about their view of that as well. Because just to say as a compliment, there's always this border rivalry between Missouri and Kansas, but the bi-state area has just done great work in taking this issue on together. And hats off to the core four. They're not always 100% aligned, but they've worked really hard to try and stay together. And I think our hospital associations, I think Tom and Herb work really well together. So appreciative of that.
Yeah.
Makes our job a lot easier. And our CMO call every week, which there is one today, with all the major hospitals in the metropolitan area on it. That is the best. So I just hats off to everybody for that bi-state mentality. It's been great. But I think the answer to the question, are we a hotspot? Well, the answers are in the numbers, and it's because we've seen a lot more rise here in the Kansas City area. The question, people aren't singling us out. The problem is we singled ourselves out. We singled ourselves out by not following the pillars of infection control around mask wearing, et cetera. You know, what we said before is that, you know, you can wait on government to try to answer that for you, or you could just do the right thing. And if you just do the right thing, you'll protect yourself and you'll protect your loved ones. I'd volunteer to take people down to the freezer if I could. We have visitor policy, can't really do that. But I'd be happy to take everybody down to the freezer if I could and show you what a breath cloud looks like with a mask and without a mask. It's dramatically different. And I think that breath cloud is where the virus hangs out. And if we could just get people to wear their masks, then that would go away immensely.
Yeah, and you know, we are singled out, but there's other cities singled out too. Omaha, for example, who traditionally hasn't had that big of a problem, but there are other cities as well, and it's not just Kansas City. And again, it's not New York, and it's not really Louisiana, who had seen those initial surges in those huge case numbers and hospitalizations. We certainly don't want to get to that point, but we understand right now it's people's behavior, and it's lack of mask wearing, it's lack of care or concern, because there still are a lot of places that people go that we can spread it in, whether that's bars late at night, gatherings, large parties, all those things contribute to that. And at this point in time, it does boil down to people's behavior, and they are not changing their behavior, and if they are, it's not rapid enough. We understand the people that are very concerned, who are vulnerable, who are wearing their masks, who are staying out of large group gatherings. But that is not the majority, just as we heard, of the people who are being diagnosed right now.
So let's first start with Herb. Herb, thoughts about that? Or why is Kansas City a hotspot from your standpoint?
I guess is we're seeing the same that we're seeing elsewhere in the country. As you indicated, the behaviors for some folks aren't changing. People made incredible sacrifices during March and April and even into May. And then when we kind of went through this reopening, they kind of relaxed a little bit. So as you all said earlier, the mask wearing, the social distancing, taking those appropriate precautions, because what we're really seeing here is community spread. No longer is this being confined to congregate facilities or meatpacking plants or nursing homes or other places like that. We're seeing it across the community, and that's a real growing concern that's out there. And so a lot of campaigns are going on in terms of Mask Up. We've got one in Missouri called Mask Up Missouri. And really getting people to think as hard as they can about the sacrifices that have been made. And we just need to keep up that effort until we, for just a little bit longer, so we can kind of get through this until we can ultimately see a vaccine or until we get herd immunity as we move forward. So we're probably going to see these flares in communities here and there as we move forward. Kansas City is one that some people have kind of focused on now, but I think you're absolutely right. It's one they've just got to continue to keep that discipline, keep up that sacrifice.
Yeah. Tom, thoughts? Agreed.
Not much to add other than to just say what community isn't subject to a surge if we don't do the kinds of things that you all are talking about. And I think it goes back to something I've thought a lot about is it feels like to me we've kind of gotten the cart before the horse. We will not get through this and reopen until people feel safe. And people will not feel safe until we have treatment, vaccine, and all those things. So if we listen to the science in the meantime, if we wear a mask, if we watch the distance that we are from other people, if we wash our hands. Science has told me that if I do those things, I can feel a little bit more comfortable being out to a certain extent. So as we talk about schools and reopening and things, we've got to go back to the health science part of it, because we're not going to feel completely comfortable until the science has brought us to the point where we have better treatment or vaccine.
Yeah, I think that's the key. And I think we had some good news over the weekend regarding monoclonal antibodies, Dana. Some more data coming out that, and toward the end of last week and over the weekend, that monoclonal antibodies appear to be effective in animal models, and some preliminary data with humans because the convalescent serum data looks good.
Yeah, absolutely. And we know there are a couple of companies that are producing monoclonal antibodies, which again are very good. So the convalescent plasma, that is for people who have recovered from the disease and are donating their plasma. The monoclonal antibodies can be made in a lab, which is very good. You have a clone of a B cell that makes a certain antibody. You can produce that. That makes it a lot easier. You can produce it in mass quantities, and then we can give it either for post-exposure prophylaxis. We're certainly looking at that aspect, but also pre-exposure prophylaxis and even possibly treatment. So there are different ways that we can use that. And again, monoclonal antibodies are not a new technology. They've been around and used in other diseases as well.
What is the short and the long-term impact of Medicaid expansion on the Missouri side? And what's Kansas' situation? Why does it matter?
Oh boy.
Great
Okay,
question.
let's do the Medicaid thing. I'm, as you can tell, I'm probably a proponent of it, but I've been in medicine for a long time. I've seen a lot of people not be able to get the care they need, so it's hard for me not to support making sure people get care. Her expansion of Missouri Medicaid took a big step in that direction.
It sure did. And so if you think about it, 230,000 people are going to have coverage that did not have it before as we expand 138% of the federal poverty level. So that in and of itself is just a huge opportunity for the state in a number of different areas. To bring all that federal money back to the state is a huge economic driver if you just want to look at it from that side of the equation. Where else are you going to see a stimulus of this size, of this order of the magnitude to bring things in? But beyond that, for the healthcare, think of what it means to this population in terms of their chronic conditions, in terms of dealing with this pandemic to make sure that we've got people in the system getting care that's out there. And what it can do to help us kind of lift the tide for everybody across the state in terms of improving their health status is just a major opportunity. Beyond that, for the business community, to have a healthier workforce is going to be very, very important. And then finally, just to make sure that we can have a sustaining system that drives more opportunity, more resources for our rural providers across the state is going to be a big deal. Tom talked about 2 hospitals recently closing in Kansas. Over the last decade, we've had over 10 rural hospitals in Missouri close. This will really help give us some more sustainability. It won't be the total answer for rural healthcare, but it's going to give us a new set of tools to help manage that. So it's really an important step for the state of Missouri.
Yeah, and again, applaud that was able to happen. What do we need to do in Kansas, Tom? Because I know we've come so close in the legislature the last 2 sessions, couldn't quite get it there. So can there be a ballot initiative in Kansas? Is that possible like it was in Missouri? Or what will it take to try and get Kansas Medicaid expansion passed? And I'm going to suspect you're going to think it's a good thing.
Absolutely, it's a good thing. And it's a good thing because people are going to be better served. All the data shows that if you have insurance, you are healthier. That's the bottom line. So I want to say congratulations to the folks in Missouri for doing that. What you've done is, most importantly, help the folks in your states, help the hospitals as well. But you've also now put Kansas on an island. We are surrounded by states that have adopted or passed Medicaid expansion. And what does that mean? Well, in addition to the fact that our citizens don't have access like they will in Missouri, what if you're a hospital on the state line and you're trying to recruit a physician to your small hospital or even in the Kansas City area, and that physician is weighing options, and on one side of the state line, they know that more of their patients are going to have insurance, and therefore they're not going to have as much uncompensated care. And on the other side of the state line, they're not. That is a factor, pure and simple, and it's going to put Kansas at a disadvantage. And I hope that Missouri, being the final contiguous state around our state to adopt expansion, will spur us on in the future.
Yeah, I hope so too. And without trying to make a political commentary, because that's not our lane, but a healthcare commentary is, and there's absolutely no question that access to healthcare improves the lives of individuals and in people, and there is no question about it, and so I think is a crying need here in Kansas for us to expand Medicaid and take care of people. I think Missouri's, you had as a family of 4, if I remember the numbers right, Herb, and you'll correct me on this, please, is that in Missouri, if you made over $5,800 a year prior to expansion, you could not get Medicaid. And now it's 133% of the poverty level, which is closer to the 18 to 20,000, which still doesn't feel like very much money. But holy cow, 5,800, that's not much at all.
No, that's not much. Around 17% of the federal poverty level, and it's just remarkable though that was that low, one of the lowest in the nation. So it's going to be a big boost, I think, again, economically and particularly for the health status of so many across the state.
Add to the productivity of the state. So, Jill?
Phone is blown up with people wanting to know, is it too soon to get the flu shot? Some pharmacies have it as early as mid-August.
Yeah, I don't think it's ever too soon. Dana, what do you think?
Yeah, I mean, the official stance is we never want to miss an opportunity to vaccinate, whether that's influenza, MMR, Tdap, tetanus. So for influenza, that's a very good question. You know, I think it has to depend on what is the influenza activity around. Right now, it's very low. I certainly encourage for all my HIV patients that I see in clinic to get it more in the late October to early November period, so that you do have that lasting immunity through to the end of the spring, when typically influenza goes until. So that's something to weigh in as well. Right now, again, influenza activity is low. Hopefully it will stay low. I think you need to talk with your medical provider about that. But again, we never want to miss an opportunity to vaccinate. However, we also want lasting immunity. And right now, there is no indication for a booster influenza vaccine. It's just one a year.
That's paid for. Even if, because I recommend the lung transplant population that they get a booster.
Yeah.
Get it early, get a booster. But that second booster is not paid for, so patients have to pay for it themselves.
And in the general population, it's not recommended at this point.
But I think if you to the point that this is a different year than ever before, and it may be, there is some evidence, at least early, very preliminary, that even influenza vaccines may offer some effect to help memory T cells around COVID. And so if that is at all true, should people get it earlier? I don't think we know the answer to that question.
Right.
But typically, as Dana said, we wait till late October, early November, so you get the coverage and the antibodies throughout the flu season. But this year, I don't know. I think vaccinate early, vaccinate often.
I think we're getting into September. If you want to push that up to early September, mid-September, that's reasonable as well. I think the nice thing about this whole thing is we were looking at the Australia data last week.
That's good.
They have seen a great decrease in their amount of calls, visits, and diagnoses of influenza to the ERs and clinics, and I think that is because of the distancing and the mask measures. So that will help as well. But again, we never do want to miss an opportunity to vaccinate.
Yeah, so that'll be an interesting thing to see what happens here in the United States. Tom, Herb, any thought about that, about flu vaccines?
Well, as I mentioned here earlier, Missouri's thinking pretty hard about what do we do in terms of the schedule. Do you go up earlier with a campaign to get people to vaccinate as early as possible? And can you, as mentioned before, can you tie that to other vaccinations, whether it's pneumococcal, shingles, all the other vaccines that people ought to be thinking about? Let's not miss this golden opportunity to really drive that thinking as hard as we can. But I'll leave it to the scientists and to the doctors in terms of thinking through what's the, do you get it earlier? Do you deal with that immunity? Because, it raises an interesting question because you talk about not only the immunity, but the durability of this vaccine. How is that going to compare ultimately to the immunity and the durability that we might see ultimately with COVID-19 vaccine? And we just need to make sure that we help the public understand the difference between those two issues and how much immunity you can get, how much a vaccine can not only give you immunity, but maybe lessen the impact of the disease. And then how often do you really need a booster? And at least when it comes to the COVID-19, can we get through a couple of seasons before we have to get a booster? That all is to be determined as that vaccine comes forward. But it's all part of, I think, what we can use this year is a better vaccine education program.
Yeah, for sure.
Ashley
I'm
wants.
sorry, and I'd like to take one more opportunity to re-educate. You will not get influenza from the influenza vaccine.
Good
It
point.
is medically proven. You may get some local reactions or maybe even a little bit of fever. If you end up getting a respiratory infection, that has been looked at as well, and that turns out to be, for the most part, other viruses that you may have come into contact with prior to getting the vaccine. Now, getting the vaccine will not 100% keep you from getting infected from influenza, but it will reduce your chance of missing work and hospitalization and severe illness, and overall decrease your chance of getting ill.
All right, Ashley wants to know, true or false, are there 6 different strains of COVID-19 virus?
Yeah, that is false.
That's what I was going to false. I don't think we know how many different strains there are for sure. Yeah.
So there's only one strain. There are other isolates that they've looked at, and based on the genome that they've been able to isolate and record, there are substitutions in those and those amino acids, things of that nature, but there is only one strain of COVID-19, even going back to the original Wuhan isolate. But there are changes, and that's not unexpected, that is known, but overall there is just one strain of COVID.
Kelly misses her daughter who 4 weeks ago, or who had COVID, and now she is tested negative, and it's been about 4 weeks. Unclear if it's from the test or when she originally got it. They say they miss her. Is it okay for her to come home?
Well, I think it's okay at this point, don't you, Dana?
Yeah,
I mean, really,
absolutely.
as long as she's been without fever for 48 or 24 to 72 hours and her symptoms are a lot better and she's tested negative, I don't think there's any concern at this point. She's probably safer having her come home than somebody else come home who you don't really know about all that about. So
Right, yeah.
I think it's probably time for the daughter to come home and see mom and dad.
Yeah, I mean, typically, in order, based on CDC or KDHE guidelines, like you had just said, they just differ in the 24 to 72 hours of fever-free, but typically you can get back into society after 10 days from diagnosis or 10 days from onset of symptoms.
Gene, who watches every single day.
Thank you, Gene. 100 of
All
those.
right.
Yeah, he wants to know, what is your opinion about, or it could be she too, sorry. What is your opinion about the safety of cataract surgery?
Oh, safety of cataract surgery.
Yeah.
You know, the way we look at it here is we do screening on everybody to make sure that they are COVID negative at the time of surgery. And I think that helps make it safe. So I believe cataract surgery is safe. And if that's something you need to do, and especially if you're having some visual impairment, I don't think I would hesitate at this point, would you?
Yeah, no, not at all. I think that will improve your quality of life. We know here at our KUI that everybody is taking the highest precautions for protection of themselves and the patients, of course.
Yep, and I'm a patient at KUI. They do a great job, and I know all the eye clinics out there are working hard to keep people safe, and I'd be totally comfortable.
Yeah.
Chrissy wants to know if we have an ECMO machine and if it has been used on any COVID-19 patients.
We do have an ECMO
We do.
machine.
That's a
I
great
don't
question.
think we've used it in a COVID-19 patient yet. Do you know?
I don't believe we have. We've had, we use that in collaboration with our cardiothoracic surgeons and our cardiothoracic ICU. I think there was a concern about using it last week, but I agree with you. I don't believe we have used it.
I know St. Luke's has used it once or twice.
Yeah.
I'm not sure we've had an indication where we needed to do it
Now,
here.
unfortunately, a couple years ago, we did have to use it on an influenza patient,
Yeah.
on an otherwise healthy 32-year-old female.
Yep.
So influenza is bad too. That goes back to get your influenza vaccines.
There you go.
All right, we have a viewer that wants to know if they're using masks if masks are enough and we can go to school and they're using them in prisons and in nursing homes, why can't we go visit mom in the nursing home? She misses her parents.
Yeah, that's a great
That's a great
question.
question.
And I think that the answer is, whereas you can reduce the risk of spread, you can't eliminate it. And nursing home populations are especially vulnerable. Tom, how are we doing in nursing homes in Kansas now, and how's the spread? Because those were a big hotspot originally.
I think just like the rest of the state and the numbers, it has begun to get better as we've learned more about the setting, as we've gotten better at treatment and treating folks. So I do think that has started to improve. But I also think that this is one of the points at which we'll be talking about in the future. After COVID, are we going to be focused more on home-based care opposed to care in institutional settings, which the system was kind of moving away from that anyway. But I think that's a question for the future.
Herb, how are things in Missouri and in assisted living and in senior living facilities?
Doing better. We had some outbreaks and we had some real tragedies in Missouri early on in the pandemic. But with the improvement in testing and the work of educating staff and working collaboratively with the state and others with the long-term care facilities, we believe we've been able to balance that and kind of turn that around. So we feel really good about it, or much better about it than we did before. And the other thing I think what folks are doing is they're being much more transparent about what they're doing in those long-term care facilities. They're not just saying the place is safe. What they're doing is they're really showing the public of how much better they are trying to make sure the residents are safe and the procedures that they're taking. So I think that action, along with much improved testing, has helped us stabilize, and we're in a much better shape in those kind of facilities. And I think the data shows that as we see that age drift go lower, many of those older folks, those older generation in those facilities are not becoming as infected at the rates they were before.
Yeah, but I think a lot of that is good infection control, and whereas masks help us, they don't 100% do it. And the problem with a nursing home is that people are A, more vulnerable, B, it's a very close-quartered situation, and so trying to make sure that there's no infection that comes in or comes out. I know my mother-in-law is over at Bishop Spencer Place, and very strict policies about how you can visit. You know, we go outside, you can have 1 hour once every 2 weeks or once a week or something where you're in a room where you're socially distanced with masks on. I mean, it's very strict. And to their credit, they really have not had an outbreak. I think they've had 3 positive patients in that community, in the Bishop Spencer Place community, and no outbreaks beyond that, which is remarkable. And it's, I think, largely because of strict infection control policy, Dana.
Yeah, absolutely. And then you just have the unknown of so many other bubbles that you're dealing with. And I think the main goal is absolutely to care for and keep those patients, those vulnerable patients, safe. And this is the way that we need to go about it right now, and maybe that will change eventually, but we all want to see our loved ones. I know that my grandma is in a facility as well, and it's hard on her and hard on my parents as well. So.
Yeah, it is hard, but it is safe, and I think that's the key, is we're trying to put safety first.
Yeah, okay, another question for Tom and Herb. Do you see any long-term changes in care models driven by COVID? And the writer mentions telehealth, but what else long term?
Okay, telemedicine we know has been great and terrific. Tom, let's start with you on this one. What other long-term changes do you think are coming?
Gosh, how much time do we have? This is a question that is talked about an awful lot right now, and a very important one. I know they mentioned telehealth, but we cannot underemphasize that. I've heard people say that we may have advanced telehealth by a decade through its use during COVID. So that's one. Another one I think is that I think I hope we will recognize that we have underfunded public health for way too long. And we've frankly tended to treat parts of the healthcare system as these separate and distinct. And I know that you all at the hospital have become much more involved in public health kinds of issues and work with the public health departments. And I think we'll see that happen more and more as we move into the future. I think maybe something else we'll see is we're going to be talking much more about how do we manufacture these things that we need in our country. So, for example, let's produce more pharmaceuticals in the United States. Let's produce more PPE in the United States so that we are better prepared for these things in the future.
You bet. Herb, from your standpoint, what do you see coming?
Obviously, the digital health, before nice to have, now it's a must have. In not only in the area of telemedicine, but apps, wearables, sensors, in-home activities, all those things that kind of fit people's lifestyle as they think about sheltering in place and things are differently. Tom's absolutely right about supply chain resources. I think local sourcing is going to become a major new initiative that we're going to see, and lots of hopefully business opportunities that are out there. Elective procedures are going to change as people move more towards robotics and stronger infection control. I think it's going to be important. The public health Tom talked about is important. Emergency preparedness, I think, is going to be reevaluated and stepped up so we can deal with future pandemics, whether it's regional systems, more stockpiling of resources as we get ready. I think we'll see a lot more in terms of dealing with inequities in the system, particularly focusing on social determinants of health and dealing with some of the disparities that we've seen for decades. But COVID-19 has really magnified as we see that. And then finally, the workforce. And an interesting thing about workforce, obviously, we're hearing an awful lot about burnout with physicians, nurses, other personnel as a result of this. But we're also seeing a renewed interest, at least across the state, and I suspect across the country, of young people who are really interested in healthcare right now because they see the heroes that work in these places and they want to be part of that. And I take it back to when I was a kid in the 60s, and I grew up in Kansas, and I was just enthralled with the space race. And as a result, everybody wanted to be an engineer. Everybody wanted to work for NASA. What we're hearing from medical schools, nursing schools, and others is that there's a renewed interest of people who want to pursue a career in healthcare because what they've seen of this, they want to help people. They want to be part of the solution as we go forward. So I think what that means a little bit is that we might see more diversity in terms of the healthcare workforce, which I think is a good thing as well.
Yeah, we desperately need that more diversity in the healthcare workforce because we know that patients do a lot better when they have a physician who looks something like them or is something like them, has a similar background to them. The advice is much better accepted and for a lot of good reasons. I also just say the telemedicine thing is going to turn rural medicine upside down in the best possible way. I think this is a game changer. I think for people who live far from healthcare, there's no question. And one of the things I hope we can all work together on is advocacy to make sure that the changes that have made telemedicine so successful in the last 3 or 4 months don't get reversed. Right. Because the things that were holding it back before were often artificial. And it's by trying to make sure we can get reimbursed for it, to make sure that people can do telemedicine from one home to another home. Right. You don't have to be in some type of office setting in order to do it. All of those things have made a huge difference in its success. And it is enormously successful. Patients love it, caregivers love it. So I think that's a game changer.
Yeah,
so
absolutely.
Time for one more?
Yes, one more question.
Debbie Ann wants to know, as we hit 100 episodes and as school gets closer and closer, could you please remind us in your calming way that this isn't going to last forever?
You bet. You know, I'm going to start with Tom and Herb. And Herb, let's start with you. Is COVID forever?
Great question. I think it's here. It's going to be part of our life as we go forward. But I think the important thing is that the things that we're learning now, we're going to learn to live with this better. Hopefully with a vaccine that has great immunity and great durability, we're going to be in better shape. But this coronavirus is going to be around for a long time. And what we as a society have to do is to learn how to live with it like we've learned to live with other diseases that are out there. And I think we're up to the task. I mean, if you think about, and you were talking about it earlier on this program, and I suspect you've addressed it in others, we've learned so much in the last 3 or 4 months in terms of how we treat people, how we're getting better medicines coming forward. And when we see that vaccine, I think we're going to find a way that we can live with this like we've lived with others. And I think that's where we're going to be.
Tom, thank you. Tom?
I don't know the answer to that question. I'm depending on Dr. Steins and Dr. Hawkinson to answer it for me. But seriously, I think there is a lot of optimism. I hear you folks several times a week. I watch this, and I do hear a lot of optimism about treatment and about vaccine. And Herb said this has and it's going to change our life, and frankly, in some good ways. I think we will be better prepared. I think we will be more thoughtful about how we act around other people. But I'm very optimistic that as we move forward, the science is going to get to the point where we're going to be allowed to get back to some semblance of what we considered to be a normal life before. It won't be the same, but we're getting there.
Yeah, I would absolutely echo that 100%. It will be here. In what form? The vaccinations, the treatment is all going to help towards getting back towards us being able to celebrate like we want to when the Chiefs win the Super Bowl as we did this year. Right now we can't do that, but as we move forward, absolutely we will have to change our behaviors for the time being, for the foreseeable future, but there is hope on the way, and we are seeing that with all of the resources and the smart people that are working on the vaccines and the treatments. It's just right now for the foreseeable future, this is what we have to do. We have to continue to change our culture and make those changes in our daily activities and what we do and how we go about doing that.
I want to thank all of our guests. I'm going to answer that question in a moment. I want to thank all of our guests for having been with us today. It's been a great program. I can't imagine a better way to have spent the 100th program than having Tom Bell from the Kansas Hospital Association, Herb Kuhn, and the Missouri Hospital Association as part of our program. Tomorrow, KCK Mayor and CEO of the Unified Government of Wyandotte County, David Alvey, joins to update COVID-19 impact and response here in the DOT. And Dr. Jed Gorlin with the Community Blood Centers a call for, you guessed it, more blood donations and plasma. We invite the media and, of course, our community to be with us. What a great day here to have our 100th episode. Before we go to our last thing, and just a heads up about this, we told you last week that KDHE Secretary Dr. Lee Norman's new series called Faces of COVID-19 had been done. You can watch the full interviews here on our Facebook page or on Twitter at Secretary Norm. At SecNorm. As we close, there's going to be a 19-year-old from Dodge City, Dodge City share some of his story. Before we do that, I have a comment. I want to answer that last question. And I've been thinking, how do we say it this year? And here's how we are going to talk about it in this, our 100th episode. It's what we've said before. Coronavirus is not a superhero. It cannot leap tall buildings in a single bound. It can't pass through walls. It does not have X-ray vision. It can't fly in outer space. In fact, coronavirus is weak. Coronavirus depends on you to spread it. It can only get from one person to another as long as it has a host, and that makes you the key part of that story. So coronavirus isn't a superhero. Coronavirus is actually weak. You are strong. And you can be so strong that we can beat coronavirus even without a vaccination, even without new therapy, by doing the things we've talked about every day. You can show coronavirus who's tough by wearing a mask, by washing your hands, by keeping your distance, by not pretending as if it doesn't exist, and going out in a party bus or going out in large group gatherings or going to a bar and acting like you can't get sick. That doesn't make you strong. That actually makes you weak. Strong is doing the things you know that you can do to keep yourself safe and your community safe. Will it be this way forever? Nah. The greatest minds in the world and across our globe are rapidly at work on therapy, which is going to come about and it's going to work. Vaccination, which is going to help us make it work. But at the end of the day, it really comes down to you. Because all those therapies, all those things are after the fact. The before the fact is what you do every day to stay strong so you can beat the weak. And in this case, it's coronavirus this week. So it's here for a while, but it's not here forever. We want you to be here forever. We want you to stay safe. So remember, do those things and still think about every day, there's just no place like home. Hang on for the video. It's pretty darn cool.
We have today with us Alejandro Rangel-Lopez, and he's from Dodge City. He's a sophomore in college at KU, and he and his family all became ill. And would you kind of walk us through the chronology of this whole thing?
My dad who first started showing symptoms the first week of May, and then it was my mom who started showing symptoms. I got tested the day after them, and I tested positive. I thought I was done with it back in, early May. Okay, I got it, we're fine. We don't have to worry about it anymore. But since then, at varying points, these symptoms have popped up. There's a lot of uncertainty with COVID. There's not, back in May we didn't have much information on it, and we still don't know how it works. I don't look at this from like an individual perspective, because it's not an individual issue. You're not just going to get yourself sick, you're going to get your whole family sick, all of your friends, people you love, and you can't guarantee that they'll be part of the group that won't experience major symptoms or won't require ventilation or anything or hospitalization, anything like that. So just have some compassion for the people that are around you. Wear your mask. It's a simple thing.